Hello, my friends. It's so good to see you again. I just love knowing that this education on menopause in general and on breast cancer in particular is going to make such a difference in your life. You've already learned so much. And here we are at video number 397, the 42nd video in the breast cancer unit. And we're finally at the point of discussing the actual diagnosis of breast cancer. Thus far, I've given you videos on all the things that happen before you receive an actual diagnosis of breast cancer. Chapter 30 is the chapter on breast cancer in my book, so if you have my book, some of what I present today here will be there. And if you don't have my book, you should definitely get it. All right, so let's address and delineate the events that would lead up to a diagnosis of breast cancer. And this is just the most common scenario. There are other routes. Most likely, your life is going along just fine, and there is nothing in the way of signs or symptoms that would make you think you have breast cancer. You are very diligent about performing your monthly self-breast exam, and you have not noticed anything unusual about your breasts. You have your annual gynecologic exam with your clinical breast exam performed by your doctor. And like you, your doctor finds nothing unusual on your clinical breast exam. So you go to the radiology department for your regularly scheduled mammogram according to the guidelines. The next day, your doctor calls to say that the radiologist has notified her of a suspicious finding on your mammogram that warrants further evaluation. So you return to the radiology department where the radiologist uses an ultrasound to further evaluate the lesion. The ultrasound confirms that it's a solid mass rather than a fluid-filled mass. So your doctor refers you to an interventional radiologist for a breast biopsy. And the biopsy entails taking a sample of the suspicious lesion under imaging guidance. The biopsy specimen goes to the pathology lab where the pathologist examines it microscopically, and the pathology report reveals a diagnosis of breast cancer. So your doctor refers you to a breast surgeon and an oncologist, and they collaborate in determining the best treatment plan for you based on the pathology report. And then, depending on your precise diagnosis, you proceed with management. Our issue for today is how best to proceed with management based on your diagnosis. The word management includes everything you do after receiving an initial diagnosis of breast cancer. So what would you do in the scenario I just delineated? In other words, what would your next step be? How would you answer this quiz question? The most important thing to do after receiving an initial diagnosis of breast cancer is A. Adopt healthy lifestyle practices before beginning any kind of treatment. B. Get multiple opinions by breast surgeons about the best surgical procedure for your situation. C. Pursue alternative therapies before having surgery, radiation therapy, or chemotherapy. D. Get a second opinion on the best treatment by a different oncologist. E. Wait 6 months and then have the diagnostic procedure repeated to confirm the diagnosis. F. Get a second opinion on the pathology report of the tissue specimen that induced the diagnosis. G. Begin treatment immediately. H. A, C, and E above. I, B, D, and F above. Well, how'd you do? Which of those choices seemed most important? You know, usually I have an idea as to how you might answer a quiz question, but this time I don't. I don't think most women think about this sort of thing before getting an actual breast cancer diagnosis. And then, when they do get such a diagnosis, the shock of it all makes considering options for how to proceed very difficult indeed. That's why I think it's good to learn about all these things when you aren't in such a dire, frightened situation. Well, here's the quiz question with the answer in bold. The correct answer is get a second opinion on the pathology report of the tissue specimen that induced the diagnosis. Nothing is more important than that. Nothing. Now, can you think of some reasons as to why it's so important to get at least one or even multiple other opinions on the pathology report? Let's go through this logically, and we'll do so by delineating the process that leads to a breast cancer diagnosis. First, notice that you did not have any symptoms whatsoever to contribute to making the diagnosis of breast cancer. This is the rule rather than the exception. In video number 389, you learned that breast cancer does not usually present any symptoms at all until it's stage 2 or stage 3. So that means you've relied on the mammogram to raise the suspicion of breast cancer. But the mammogram merely indicates the possibility of breast cancer in a very vague way. There's nothing specific about it. It hasn't told you that you do not have breast cancer, and it hasn't told you that you definitely do have breast cancer. And it certainly hasn't told you what kind of breast cancer you have, even if you do have breast cancer. But despite these limitations, even though symptoms would have only alerted you to the presence of breast cancer late in the game, the screening mammogram has raised the suspicion of it early in the game. And that leaves you with the next step, biopsy. The biopsy is what gives us a tissue diagnosis. The tissue diagnosis designates a few things. First, it designates the kind of cell that has become cancerous. It could be any of the cells that exist in your breast. The most common ones tend to be lobular gland cells and ductal skin cells. Second, it designates the personality of the cancer cells. I've taught you that the term for this is differentiation. The degree of differentiation determines how aggressive the cancer cells are. And there are 3 degrees of differentiation. Mild, which we call well differentiated, moderate, which we call moderately differentiated, and severe, which we call poorly differentiated. And the degree of differentiation plays a huge role in determining the treatment. So you want a biopsy specimen that does a good job of pinpointing the degree of differentiation. So how does one perform the actual biopsies? Biopsies for the diagnosis of breast cancer are usually one of 2 kinds. They are usually either fine needle aspiration biopsies or core needle biopsies. A fine needle aspiration biopsy is a procedure in which a radiologist uses an ultrasound to localize the suspicious area that warrants sampling, and he or she inserts a very fine needle attached to a syringe to withdraw a tiny bit of fluid or tissue from the suspicious area. A core needle biopsy is a procedure in which a radiologist uses an ultrasound to localize the suspicious area that warrants sampling, and he or she inserts a larger needle attached to a syringe to withdraw a core of tissue from the suspicious area. So the core needle biopsy involves cutting out a piece of tissue in the suspicious area. Now, this cutting out of the piece of tissue can be done in one of 3 ways. The doctor can plunge the needle in and out of the suspicious area manually, or the needle can be attached to a spring-loaded tool that moves the needle in and out of the tissue quickly. Or the needle can be attached to a suction device that pulls the tissue into the needle. The big key is to understand that no matter how you obtain the biopsy, It is merely a sample of the suspicious area. The problem is that the biopsy only collects random pieces of the suspicious area. And the ultrasound cannot visualize the tissue clearly enough to ensure that you're getting the parts of the suspicious area that provide the most accurate diagnosis. Let me demonstrate what I mean. Here I have a tiny straw. It will be our biopsy needle. And here I have a strawberry. The strawberry represents the suspicious lesion that warrants biopsy to determine whether or not it's breast cancer. Now, a biopsy, regardless of whether it's a fine needle biopsy or a core biopsy, involves inserting the straw into the strawberry. So if I visualize the strawberry using an ultrasound and insert the straw into it, I'll obtain my biopsy specimen. But look, notice that this side of the strawberry appears fairly normal. But this side has a bruised, more damaged area. What if the straw only removes cells from this more normal appearing side and misses cells from the abnormal looking side? In that case, your diagnosis would minimize the true degree of the severity or differentiation of the cancer. In other words, it might indicate the cancer's personality is mildly abnormal rather than severely abnormal. On the other hand, this damaged area can be so tiny that it does not represent the true personality of the cancer. And if this more damaged area constituted only a tiny speck of the lesion and your biopsy sampled only the more damaged area, you could end up with a diagnosis that is much worse than the actual cancer. So it can go either way. The bottom line is that a biopsy only samples some of the tissue. It does not give you a complete specimen that enables examination of the entire suspicious area. You learned in the Alzheimer's unit that you cannot make a definitive diagnosis of Alzheimer's until the time of autopsy, when the pathologist examines the entire brain. And the same thing can be true of breast cancer. Sometimes the biopsy specimen does not reveal the same thing that a surgical specimen reveals if the entire mass or the entire breast is removed. So this brings us to a common phenomenon in the world of cancer in general. When it comes to cancers, there are two levels of diagnosis. There is a preliminary diagnosis and there is a final diagnosis. The preliminary diagnosis is the diagnosis assigned to the cancer based only on the biopsy results. It addresses only the degree of differentiation and little or nothing about the degree of spread. It also represents only a random sampling of cells rather than the entire tumor. But it isn't until you undergo surgery and remove the entire mass, assess surrounding tissues, and sample lymph nodes that you get a final diagnosis. The final diagnosis is the diagnosis assigned to the cancer based on surgical findings as well as biopsy findings. So one thing to consider if you get a diagnosis of breast cancer is whether or not to have a second biopsy to compare with the first. But even if you do, understand that it will still constitute only a preliminary diagnosis. Of course, this means putting yourself through an uncomfortable procedure all over again. Fortunately, that is not usually necessary in most circumstances. As long as the radiologist who collected the specimen is skilled at performing breast biopsies, you do not need to undergo a second biopsy. A different radiologist performing the biopsy is not likely to produce a specimen that reveals a different kind of breast cancer. But it is possible for it to reveal a different degree of differentiation. So if you have any doubts or you just prefer a second biopsy, by all means, get another one. Once the biopsy specimen goes to the pathology lab, the pathologist performs a standard set of steps to prepare it for microscopic evaluation. Collectively, these steps are called fixation. There's no reason to doubt the ability of any pathologist to perform these steps. It's what they do all day, every day. And these steps result in being able to look at the cells of the biopsy microscopically to determine the personality of the cancer cells. So fixation does not present any issues in terms of making the diagnosis. Next comes the actual examination under the microscope. When the slides are ready for evaluation, the pathologist looks at them under the microscope with his or her own eyes. And based on what he or she sees, they label the specimen with a diagnosis. And this diagnosis is what you receive as your breast cancer. But stop a minute. Think about this. If the pathologist is looking at the slides with his or her own eyes and deciding what it shows, it's subjective. One pathologist might designate it as one diagnosis, and another pathologist might designate it as a different diagnosis. And depending on how those perceptions differ, your entire course of management could change drastically. This is the case because the pathology report dictates everything in terms of treatment. Way back in the unit on cancer in general, I taught you that cancers have personalities. And this microscopic pathology report is what identifies the personality of the cancer. Some breast cancers are very aggressive and fast growing. I call them birds because, like a bird, they can travel very long distances in a short time. Other breast cancers are moderately aggressive and grow at a slower, steadier pace. I call them rabbits because, like a rabbit, they progress, but in a predictable manner. Ignore the dress. Sometimes finding just the right toy to use as a prop isn't that easy. And yet, other breast cancers are minimally aggressive or not aggressive at all and grow at a very slow pace. I call them turtles because, like turtles, they creep along ever so slowly. Whether your breast cancer is a bird, a rabbit, or a turtle is somewhat in the eyes of the pathologist who reads the slides. In other words, the demarcations between mild, moderate, and severe differentiation, or mild, moderate, and poor differentiation, are not clear cut. And then there's the dilemma between what constitutes invasive breast cancer versus breast pre-cancer. Now, you would expect for there to be very clear delineations between this, which is pre-cancer, and this, which is invasive cancer. But surprise, surprise, there aren't. What constitutes invasive cancer to one pathologist may be merely pre-cancer to another. And believe it or not, this is an area of great controversy. It is very common for pathologists to disagree on diagnoses. If there isn't even agreement on the initial diagnosis, you can't be sure that any one pathologist's set of eyes are accurate in their assessment. So why rely on just one set of eyes? Having another or multiple other pathologists read the slides is so easy and tremendously beneficial. And don't use a pathologist who is in the same institution or the same group as the one you used the first time. You can use a pathologist anywhere. You don't even have to be present for another pathologist to read the slides. You can mail the slides to someone across the country if you wish. If there is consensus between different pathologists, then your diagnosis is pretty firm. But if there's disagreement, it's vague. Having at least one second pathologic diagnostic opinion is absolutely the most important thing you can do, especially in all cases of carcinoma in situ. Carcinoma in situ is the most confusing, convoluted, overtreated entity in medicine. There is no agreement as to what constitutes carcinoma in situ among pathologists. And pathologists are not the only ones confused by CIS. Everybody's confused. Oncologists, surgeons, radiologists, gynecologists, general practitioners, and patients. Everyone's confused. Its oxymoronic name is not the only quandary it presents. So before you accept the diagnosis and begin any kind of management based on the diagnosis, get at least one second opinion on the pathology report. I cannot stress this enough. So many women are getting treatments for CIS, which is pre-breast cancer, that are intended for full-blown invasive breast cancer. And most of these women don't even realize that they had pre-cancer instead of invasive cancer. Once you have an accurate diagnosis based on the pathology of the breast biopsy, you are ready to address your treatment options. And the treatment will be dictated entirely by the pathology report. That pathology report pretty much dictates everything that happens from that point forward. So take the time and make the effort to ensure that your pathology report is accurate. And since treatment follows the pathology report, that's what will follow this video, treatment of breast cancer. So come back in a week to hear about that. Your summary is simple. The most important thing to do after receiving a diagnosis of breast cancer is get at least one second opinion on the pathology report of the tissue specimen that induced the diagnosis. Between now and next week, you can find me on Facebook, Instagram, Pinterest, and Stories. You can also subscribe here to my YouTube channel and to my newsletter. And you can certainly go to menopausetailor.me to schedule a life-changing and life-saving consultation. Bye!